everyone. This is Samira Daswani, the host of the podcast, The Patient from Hell. I have with us, I think, a superstar who has been on our podcast before, and her episode, for you guys listening in and watching this, love. So I'm going to welcome back Dr. Karen Wernli to our episode.
Samira, great to see you again.
Good to see you. It's been a minute.
Or like almost half a year or more, right?
Yes. It's true.
And I think you've had some big life changes recently.
I did get married in
Super
December.
Exciting.
And it was really nice. I don't think people prepared me for feeling happy. It sounds weird. Like, I think I've just gotten so used to, like, I don't know, preparing for, like, the darker side, you know, cancer diagnosis, all the fun stuff that comes with it, all the wedding planning. Everyone else is like, you're going to be super stressed out. You're going to be, like, you know, project managing, all true. But no one prepared, like, the happy part. And I was like, that's funny. I didn't expect that. And yeah, so it was really nice. So.
I've been married for almost 24 years at the end of May. I know. What? I was like just a wee baby when I got married, really. And my mom had died the year before. Oh. So it was the first time the whole family was all coming back together. And it was a happy day. It was just a lovely, beautiful, happy day. So I'm so glad to hear that you had a happy day.
Thank you.
Or days, maybe?
Days. Definitely days. Definitely days. Indian weddings, definitely days.
Which maybe is what it should be, right? Because how are you supposed to cram all that happiness in a 24-hour period plus sleep?
I have no idea. I think that's a question for you. I had it for 10 days, so it was a little bit longer than 24 hours.
Yeah, right.
No, it was really nice. It was very nice. It was, I think it was the first time, honestly, since diagnosis, that I think cancer was mentioned once in the 10-day period, which is, I mean, we work in oncology, so like that almost never happens anymore. Like, I don't think I go by any single day where the word cancer is not mentioned, right? Like, it's mostly every hour, every minute of every day. Mm-hmm. So to go through a 10-day window where that was not mentioned, it was, I don't know.
Liberating?
A little bit, yeah. It was liberating. It was like my identity is not tied to it. And I think because I work in it, it does feel tied to it very often. And it wasn't. And it was just, I don't know. It was good.
That's really lovely. I'm really glad to hear for you.
Thank you. Tell me what's happening in your life. Half a year.
Yeah, I thought about this because you sent me an email about it a few days ago. I was like, what has been happening? And then I mentioned it to the art group yesterday. They're like, are you going to talk about us? So here they are again.
There we go. Amazing.
Still painting once a week. It's incredible.
Is that a piece of yours at the back?
No, that's a piece of my children's art.
Sorry. Ouch.
I have something on my phone.
All right, we're ready?
Yeah, maybe that's what I could share. I know, just like everybody, right? Like the delay. We did black and white.
Done. You painted that?
Yeah.
Whoa.
There, color sweater.
Wow. Yeah, it's stunning.
8 hours, 4 sessions times 2 hours, black and white only.
That's pretty cool. I don't think I've actually, no, I have seen, that's oil on canvas or acrylic?
Oil on acrylic, oil on canvas.
I think I have seen a black and white only portrait in oil on canvas. I actually can't think of, I mean, Picasso maybe, but outside of him, I also don't think he was oil on canvas. I think it was a different medium. Like Guernica was mural, is that right?
I don't know. But now I feel like I should tell my art teacher and then we'll discuss it next week.
Okay. All right. Done. You have to tell me what happens in the class. I want to know now.
Yeah, I think what I was thinking about in terms of what's going on in my life is just a lot of transitions. My youngest is going to college. There's been a lot of illness and death that comes from illness in family members. So just a lot of transition right now.
Would you mind talking to us about what that feels like?
It's unmooring, right? It's totally unsettling. It almost has that feel like of when in the pandemic in the early days where people are like, what's going on today? Because you don't, every day is something unexpected or can be. Yeah.
Yeah.
Talking to you makes me wonder why we don't talk more often in between the podcasts, right?
Talk more often between the podcast.
I think we're both too busy.
Well, we can always make time.
Samira, I don't know if I sent this to you in email, but the best gift of being able to do this podcast is like all of my friends, not in research, not in this academic life, were like, oh my God, I knew you, but I didn't know you. Like all of a sudden, you see somebody so familiar because they see me in a personal context. And then they hear me talking about science where they're like, this was incredible. Like I learned so much. And I knew you knew things, but I didn't know you knew those things. So that has been such fun feedback to receive. So we'll see what people think of this one.
Done. I love hearing that. I love hearing that. That was actually honestly the intention behind the PCORI grant. That was really the intention. Like when we wrote the grant, one of the things that we spent time writing about was in the world of science. As a patient, you see the clinician, right? You see the oncologist. Right. You see the medical care team. You see the nurses. But we almost never, ever get to see the researchers. You never get that. Right? We don't get to see them. We don't get to see their lives. We don't get to see how they think. We don't get to see how they design science, how they make what they do, and their stuff affects us. It's their work that directly impacts the care we get, and we never do. So to hear that, makes me so happy. That was exactly the point of the grant. So.
And I should say, not even an audience for which this might be geared for people who maybe are personally experiencing cancer. This was primarily feedback I got from my friends who do not currently have cancer, hope never have cancer, but certainly have experienced it within their lives. Yeah.
Yeah. Karen, the funny thing about our podcast, and I'm learning this, and it's all new. We came into it with the intention of supporting people who are going through it right now. And what we're learning is, and it sounds so, I don't know, in some ways really dumb, but what we're learning is everyone is impacted at some point. Every single one of us is. And it may be happening now, it may have happened in the past, and it may happen in the future, either to you or to someone you love. And somehow our hope and intention with the podcast is that it gives you something to anchor on, right, in that moment of transition. Because entering into illness and leaving illness are all, including the illness part itself, it can be really, really scary.
Super scary.
Hopefully we get to help a little bit. All right, Karen. Let's maybe jump into some of the sciencey stuff.
Okay.
I had a harder paper for you this time. It was hard for me both from the scientific aspect, but also just from the value of research aspect.
Okay.
So maybe we can start with the sciencey part and then go into like just broader value of research part. And the sciencey part, can we just start with preoperative breast MRI? What in the world is that, and why do we need it?
I know, you think it's an easy question, and it's actually kind of a hard question. And I think I'm just going to jump to why it's hard,
Okay.
and then we can just roll it back.
Good.
If that's okay.
Totally okay.
The reason why it's a little bit hard is we did this survey of women who were newly diagnosed with breast cancer, maybe had completed most of their treatment. So when we recruited them, they were like 6 to 18 months from their breast cancer diagnosis. And the question that we asked is, what type of imaging did you receive prior to surgical intervention? Let me just scroll. I actually have the paper up, so I could go back to it to remember things I couldn't remember. Yeah. Which test did you receive to screen or diagnose your cancer? So that's a tricky question, right? Because when you look at preoperative breast MRI, it's what type of imaging are women self-reporting that they received prior to the time in which they had their surgery.
I see.
And some of them, it's hard for me to know exactly, might have received a breast MRI to screen for breast cancer. And some of them might have received a breast MRI in the diagnostic workup for their cancer. The science itself was compelled based on the diagnostic workup and the use of advanced imaging during that phase. But it could be mixed with screening breast MRI.
I see. Maybe we can go to why is it an important question to know? Like, why study it?
Yeah. Breast MRI has been increasing like over the last 20 years. More women are using it for screening, but also more women are using it for diagnostic purposes. Like 10 years ago, we published this paper that was looking at why women were having breast MRI and sort of the staging and getting prepared for surgery was a high proportion. I don't quite remember, but maybe like 40%.
Well, okay.
And it's my understanding that at that time, like 10 years ago, NCCN guidelines were sort of like, you can use this test, but if you're suspecting it's cancer, you should be going to biopsy. You shouldn't be using this test to further define tumors. I think that some practitioners have really incorporated it in terms of being able to really understand the tumor better, so that the surgery is better. And some studies had recently come out and said, you know, this could delay the time in which women actually start treatment. Or it could be reassuring to women to know that they have gone through some additional tests to make sure they know sort of what their tumor structure is like. Maybe that's reassuring. And so we didn't really know, are these, you could say, additional imaging tests making women nervous or regretful in terms of what's happened in her diagnostic pathway? Or did it make no difference? Or are they happy with it, right? The other reason you can see when you look at the tables, we've stratified it or looked at two separate groups based on breast density. And that's because the grant itself was focused on whether or not there were differences based on breast density, knowing that women who have very dense breasts or heterogeneously dense breasts might be more likely to get advanced imaging or more likely to benefit from advanced imaging than maybe women who did not have dense breasts.
This is where life starts to intersect into our podcast in a really fun way. I'm going to take us on a tangent. I apologize up front for the tangent.
Okay, I'm super excited. Where are we going?
Dense breasts. So sorry. I promise you it's a tangent. Well, maybe it's not that much of a tangent, but it's a tangent to the study anyway. So I have dense breasts. Every time I've done a mammogram, every single time for the last 4 years, it has been, you have dense breasts. Well, it doesn't say you, but the patient has dense breasts. Additional imaging is required. Great, we know this. It's established. I switched centers because insurance had to switch. Long story, had to change centers, not because I wanted to. Insurance shifted. I'm in a new system. The new system refuses to give me anything but a mammogram. So I am currently smack in the middle of this, being like, guys, biology dictates. Oh, and by the way, guidelines dictate. I need more than a mammogram. And it is such a fascinating place to be. Very frustrating, I might add. I had a back and forth with the RN, and I was like, I copy pasted the link of the guidelines. I highlighted the guideline, and I was like, I am pretty certain that I am reading this the right way. And the fact that I have to do that, I think is ridiculous. Sorry, that was my rant. This is why it's a tangent, and it's a rant. But it is. Why is that true? We have the research, we've had it for years, guidelines have shifted, and yet we're sitting in this world where it just doesn't make any sense. So, it's a philosophical question for you.
Tricky. Right?
Yeah. Yeah.
And I think that, particularly for young women, there's this benefit of additional imaging. We also know that breast density changes as we age and go through menopause. So women who used to have dense breasts might not have dense breasts later. But breast density is an independent risk factor for breast cancer. And it's not only because it can mask breast cancers, it independently of masking is a risk factor for breast cancer. Yes. And also that inter-rater reliability of breast density can be is not as high as you would think it is.
Can you say that again? I don't think I caught that. What was the term?
There are four breast density categories, right? Women can have almost entirely fatty breasts. Radiologists get that. Great. Women can have very, very dense breasts. Radiologists see that too. But you see a lot of differences between the categories right next to each other, that you could be this category or that category, right? Across the spectrum of those four groupings. And we've defined dense breasts as whether or not you're in the two categories that have dense breasts, or the two categories that we define as having non-dense breasts. But there's probably a fair number of women that maybe fall into either of those categories. For example, I did. I had my first mammogram last summer. The first time it didn't say I had dense breasts. Let's call it radiologist A. The second time, because I was recalled, I did have dense breasts. So that's what I'm saying.
I see. Huh.
It's messy.
Can you help me understand the difference between fatty breast and dense breast?
It's about the architecture structure, the actual structure of the breast, and that the way in which it displays on this x-ray then is either very dark because it's a fatty breast, or has all of this tissue infrastructure because it has a dense breast.
Oh.
And is seen to be related to hormones, but nobody's really sure.
Okay. That is actually super helpful. I think I learned something completely new today. I was not expecting to. That's pretty cool. It's very cool. I didn't know there were 4 categories of dense breasts. I didn't realize that was like not a spectrum, but like a spectrum.
You could call it a spectrum because it goes from fatty, non-dense breasts to extremely dense breasts.
Interesting.
Four categories. It's not a binary measure, and it's not consistent, and it changes.
Does it change by time of month?
I don't believe it does. I don't think it does.
Fascinating. Sorry, we're in a rabbit hole I was not planning on being in. But it's fascinating. I actually didn't know that. I didn't realize that there was a architecture, and that it sounds like, and going back to guidelines, it sounds like you need to be on the 2+ of like dense breast to qualify, again in quotes, qualify for advanced imaging.
The radiologist gives a range, A, B, C, D score, and dense breasts are the CD category.
Okay. Interesting.
They have terminology that goes with that. The FDA has been in the works for some time in order to have mandatory reporting. As you probably are aware, some states have already adopted this, but it will be nationwide as of September of this year, that all women would be notified as to whether or not they have dense breasts.
Whoa. I did not know there was state reporting on that either. Wow. Okay. You know what's going to happen after this podcast, right? I'm going to go and pull up my last mammogram report.
You, it probably hasn't changed, right? Like, you've had some big life changes, but not such big life changes.
Yeah, no. I also am not on hormone therapy, and I'm not menopause, so
right.
It should not have changed dramatically within a year, right? So, yeah, I have to look at this now. Now I'm going to go down that rabbit hole post this podcast. It's going to be great. You may get a couple of emails from me. I apologize.
It's okay.
Interesting. Okay, all right. So going back to the study, we have dense breasts, the table.
Yes.
Breakdown. We're doing a retrospective. I'm going to scroll back up. I'm going to go back to something you said about user preference. Wow, my brain. Patient preference. This is what happens when I work in digital health, not while doing podcast stuff. My head is like user preference. Oh. On the patient preference side, the question I have for you is, very often, patients don't know what imaging they got or why they got it. So how do we value the patient's perspective on what imaging test they got and whether or not it was helpful or not helpful?
I think that that's a really good question, because I think that's accurate, right? You are told there's something we see on imaging and we want to do some other tests.
Yep.
And in that moment, you are totally disarmed. So who are you to say, wait a minute, is that the right next test?
Correct. Yeah.
So it's really about women's perceptions of that process. I think, in a way.
I see.
And whether or not that process in and of itself was helpful. I think this is actually a good time to go to the table with the primary results.
Yes.
I'm just going to scroll through it and look at it myself so that I don't get it wrong. So this is what I think is interesting. So we had 2 outcomes that we were looking at, and the first one was around decision quality. And this is really, it's a standardized measure. It's been used in other studies, other breast cancer studies. So there are other reports of it in different populations. And that's what makes it easier or convenient to be able to compare what we see in our study to other populations. And this is really has been used a lot around shared decision-making, like the quality of shared decision-making. How well did patients think that their doctors talked to them about treatment choices or next steps or something? And so our primary results, and we're going to look at the adjusted ones. That's where we take everybody in our groups, mathematically in fancy models, take care of factors that might make the groups different to make them more similar so we can compare them. And what we see when we don't worry about breast density yet is that women who did receive a preoperative breast MRI had higher reports of decision quality compared to women who didn't get a breast MRI. And it's, as we say, statistically significantly different. And we hypothesize that maybe this is happening because if you get this other test, maybe your doctor's just talking to you more a little bit about what's going on with you.
Yeah.
And maybe that additional conversation, because maybe you understand something better about it, makes you feel better.
Yeah. Can we talk about the measuring tool, like the decision quality tool?
A little bit, but maybe not a lot.
Just a little bit to help explain what that means. Right? Like, what is evaluating decision quality mean? Because I think where I'm getting a little tripped up is, so the perception I got, it's more of like how we measure whether the decision was good retrospectively. I don't know if the question makes sense.
Yeah.
Right, because decisions are being made now, and then there's the like look back. Was that a good decision or not? But now, when look back, you just have more data, right? So how do you balance that?
I think that one of the things you're asking is, if we talk to women or had them do a survey the day after they did this, how reliable is it this response compared to the response that we're getting today?
Yes, that's a much better way of saying it. Yes, correct.
I don't really know the answer to that. I know that this measure has been used multiple times and has been validated. And so I think that what that means is that if we give it to people on different days, we consistently get a similar result.
Got it.
But what I don't really know is whether or not if you actually waited like a year, will you get a different result? And you're right. I think this is important. I think we talked about this before.
Yeah.
The women that participate in the survey are not necessarily representative of all the women who have breast cancer in the United States. In fact, these women are highly resourced, highly educated, white women who are the ones most likely to participate in surveys like this and are the ones for whom we have the most research about outcomes. And their experiences may not reflect all women's experiences. And so I think you also have to take that into consideration when you look at these results.
Mm-hmm.
That this might be reflective of a segment of the breast cancer population that may not be generalizable to all women with breast cancer.
That makes a ton of sense to me.
So what's interesting in our results is that when we look at the group of women who have non-dense breasts and we look at the group of women who's dense breasts, the results are a little bit different. They're not statistically significantly different. They're a little bit different. When we look at women who have dense breasts and the difference between those who received a breast MRI and those who didn't, their responses on decision quality are pretty similar. When we look at women who have non-dense breasts, the women who had a preoperative MRI, their responses or their reflection on decision quality is a little bit higher than those who didn't get breast MRI. We did say at the end. So it's a series of questions. I can't remember how many questions are asked. You can imagine it's something like 5 to 10 questions that you summarize, and then based on this summary, you're able to compare between groups. And so the difference that we're seeing is like a woman answering one more question positively. And so it's hard to know whether or not these differences, even though they're statistically significantly different in the whole population, are clinically different or meaningfully different. And their overall values were really similar to what we've seen in other published populations of women who've had breast cancer. So it's likely that preoperative breast MRI really doesn't do anything in order to alter the pathway.
If you had to redesign the study today, what would you do differently?
I'd want to know whether or not it was a screening breast MRI or a diagnostic breast MRI.
Yeah.
I've also done very few surveys. And so what I would prefer to do is be able to look at maybe standardly collected patient-reported outcomes that might be in an electronic health record, so that you could assess outcomes for all women, maybe even if it's just in one center, based on utilization. Because also, as you said, women might not remember whether or not, what kind of imaging they got, and maybe that was also a problem.
Interesting. Would you still use decision quality as a measure?
Maybe.
Okay.
Maybe.
I'm gonna zoom out completely from the PCORI study.
Okay.
I would love to know what you're working on right now.
Do you mean that? Like,
yeah, actually, I am truly serious. Like, what are you working on? Like, whatever you can share. I understand that there are parts that you may not be able to share, but whatever you can share in terms of like, what are you studying today? Why does it matter today? Because a lot of times,
because it's sort of like a left turn into some other things, and so I'm just going to warn you, we're going to take a,
I think we have established you and I go on tangents, so it's okay.
Okay. I'm leading a pragmatic trial to improve adherence to lung cancer screening using 2 patient-centered interventions.
Cool. Okay. What are the 2?
Pragmatic trial means that rather than coming up with some very strict criteria for entry into a randomized trial and then seeing whether or not this intervention that you have produces a signal, we're doing this study only at KP Washington. Everybody has recently screened for lung cancer screening, so they've chosen to participate in screening. And we're just trying to deliver some communication tools that would encourage them to screen again on time in 1 year. One is a video-based intervention that we deliver very soon after they get screened. And the second is a reminder that starts with placing the order that goes to their PCP to sign in order to kick off the scheduling process.
Cool. So one, if I'm hearing this right, one is a video where the burden, I put burden again in quotes, to do the screening and schedule it is on the patient. Mm-hmm. And the other one is clinician driven almost.
It's multi-level targeted. Mm-hmm. So as soon as the physician signs the order, we start delivering outreach to patients to encourage them to call and schedule their appointment.
Very, very cool. Very cool.
It addresses 2 barriers to screening. Everybody who screens is supposed to go through shared decision-making with their provider. But I think it's like harms and benefits of screening. It's not like and it treats as if screening is a one and done sort of thing. But it's a program of screening. It's like participating in breast cancer screening or lung cancer screening or colorectal cancer screening, I should say. Yeah. or nearing the end of accrual into our study. We conservatively estimated that we'd get just over 1,600 participants, and we've over accrued in a shorter period of time.
Oh, that never happens. Very cool.
Never happens because lung cancer screening is expanding and some more people are being screened. Our protocol paper just came out, so I can share that with you later.
That's awesome.
So that's super cool. I'm also leading a study that's part of a CDC-funded network looking at influenza and COVID vaccine effectiveness. So we do recruitment in clinics. I know, I told you.
That's great. Right.
It's so much fun. People say, but that's not what you did. And I was like, yeah, I know, but the skills translate and it's clinical research. So it is what I did. It's just a different topic.
Lung cancer screening, this is low-dose CT?
Yes, low-dose CT.
And smoking status doesn't matter?
Smoking status does matter. To be eligible for lung cancer screening, you have to have at least a 20-pack year history. So consuming 1 pack of cigarettes per day for 20 years or longer. And the U.S. Preventive Services Task Force guidelines currently state that you either need to be currently using tobacco or have quit within the last 15 years. And you can see that it can become kind of problematic. And because of that, the American Cancer Society in the fall recommended that the quit time since quit was really irrelevant, and recommended that if people meet the pack year criteria, that they should be eligible for lung cancer screening.
What about asbestos exposure?
They do not account for workplace exposures in the risk assessment.
Interesting.
Yes. It's been just really interesting work. I get to work with 3 incredible patient advisory board members who've just been so giving of their time and expertise.
That's awesome.
And it's the first study that I'm leading where I designed interventions. I've worked with other people to implement studies that they've designed, but I really started wanting to understand what the barriers were and then how we could address them using human-centered design principles. And identified these 2 areas in terms of education as being a critical one, but also reminding both the physicians and the patients when they needed to come back. Some people can do it, get it. They get it right away. I say that both from the patient perspective and also from the clinician perspective. Some people need extra help. And you're just trying to make it easy for people to do the right thing. You're just trying to make it easy. That's all.
I love it. Thank you for sharing. That was awesome.
It is not funded by PCORI, but I would be happy to talk to you about these study findings when they're available in a few years.
Don't, happily. Lung cancer is near and dear.
Yeah.
I'm doing a lot of lung cancer content generation actually recently because it's so complicated. The more I learn about it, the more I'm like, whoa, this is just breast cancer is easy. I don't mean this from a patient perspective, guys. Survivor here, it's not easy, but from just a scientific lens and a clinical lens, my God, lung cancer is complicated. Anyway, so we've been inching our way into it. So
it's also been underfunded, underappreciated. There's been a lot of stigma in healthcare. Yeah. In that study, because it's a pragmatic trial, people don't consent to enter. So we delivered these low-risk communication strategies, and then we're able to measure outcomes from the electronic health record with permission from our Human Subjects Committee. And then I ask people to participate in a survey where I notify them about the research. And there's differences between who's in the main trial in terms of patient demographics and other factors. compared to those who are in the survey.
Interesting. Interesting. I have like 18 questions on informed consent, but we will not go there because I'm watching the clock, and if we go there, we're going to be talking for another.
Maybe for another
consent.
I can send you a paper about that too.
That would be awesome. We should definitely link to it because consent has gotten so complicated, and given all of the noise right now, not noise, I think justifully, that's not a word. The news right now on health data, security issues, privacy issues, I think the informed consent conversation is actually a really important one when it comes to research and participation and the use of medical data. So we should definitely have a conversation on that. Near and dear to my heart too.
I would be happy to, because I've become such a big fan of the structure of this trial for interventions that meet the criteria, low burden, low risk, communication type strategies. This isn't appropriate if you want people to take medications, for example, drugs for the first time. Not appropriate.
I really like it, actually. I really like it because it sounds like a lot of stuff in the world of like appointment reminders,
right,
clinical workflow, and as to when you get the like PDF overview of your disease, the reminders for when to ping your doc about. It sounds like it sits in that world, and that feels very practical, almost like the quality of what's the word? There's a IRB sometimes have a waiver, right, on quality.
Do you mean like QI?
QI waivers. So it almost sounds like it's in that vein, but not exactly. But like the entire study is designed with keeping some amount of that in mind.
I think that that's intended to be the point, because if you want to make system change, you need to understand how it's going to impact at the system level. Right? How you identify people have to happen at the system level. How you deliver the interventions have to happen at the system level. And so it's less about like, is this intervention working? And more about how do these interventions work when we make this system change.
Very, very cool. Okay. I learned so much. I always learn so much in our conversations. I'm going to try summarizing because we really did go
like all over the place.
We went everywhere today. Okay, so summary number 1, my favorite, personal favorite. Breast density. There are 4 types. Who knew? ABCD, that's 4. And if guidelines do say that if you have high dense breasts, you may be eligible for advanced imaging. The second thing I took away was the use of decision quality as a measure to understand patient perception on the quality of decisions being made. And then we went into study design principles, both retrospective, and then we ended up in pragmatic trial design as an option that is available today for things that are low risk and really targeted at system improvements.
Yes.
Anything you want to add to that?
No.
Karen, this is always, as usual, been such a pleasure. I love connecting with you. The next time we do this, I want to know what your art group thought of black and white oil and canvas painting, and whether there are others out there who do that.
We'll have to research that.
Yeah, otherwise you may be the pioneer here. Just saying.
Unclear.
That's our hypothesis that we're going to end this podcast with. Thank you for being back on this show. I really appreciate it.
Thank you for having me, and I can't wait to.
This episode was supported by an award from the Patient-Centered Outcomes Research Institute.